tell my parents. I go, we need to find what mechanism is causing this dysfunction, whether it's functional pain or pathologic pain, meaning there's organicity involved that causes some dysfunction. We need to still feed what is that mechanism that's igniting it. That's very important, and that's what our workup does.
At what point during the evaluation of your patients you decide to start? Welcome to another PGA podcast.
Great.
We have today a very distinguished guest, uh, Dr. William Muñios, Bill
Thank you.
Muñios. He's been practicing pediatric gastroenterologist for a very long time, and actually one of the founders, one of the two founders of the group.
Thank you.
And so probably we're going to dig a little bit also about the history of pediatric gastroenterology in Miami now that we're having today
right.
as a guest before jumping to our topics of today, which is abdominal pain
Abdominal pain.
in pediatrics or in kids. So tell us a little bit about yourself,
Oh boy.
Bill. So
Go
like
way back.
yes, like it. So what year was it that you joined Miami as a pediatric gastroenterologist?
As a pediatric gastroenterology, I started in 1990.
1990.
I did my residency at then it was Miami Children's Hospital. Actually, it was the first year. It went from Variety to Miami Children's Hospital. It used to be Variety Children's Hospital in the, let's say, the late 70s, and I actually started as a resident in 1985 and had 3 years at Children's, and then I went to Emory in Atlanta and did 2 years of pediatric gastroenterology there. Back then, it was a 2-year program. It was a third year. You would do a third year if you were interested in staying in the research branch. But I knew I wanted to be take care of patients and
A clinical gastroenterologist.
clinical gastroenterologist. So I came back in 1990 and started a solo practice. Basically,
There were not many pediatric
there was
gastroenterologists in Toronto.
there were actually at that time in 1990 Dr. Jesse Reeves Garcia had just joined the original gastroenterologist at Children's, which was Dr. Ruiz Isasi.
Yeah, actually, I just saw one of the patients that you helped
Yes.
me in the hospital from Honduras.
Right.
And the father of the patient was a patient when he was a kid of Dr. Ruiz Isasi
He
back
was.
then, in 1991.
In 1991.
So you were here already?
I was already here, and I might have even seen him.
Yes.
Yeah, I would work with Dr. Ruiz Isasi. We weren't in the same practice per se because I was outside in the community, but he was the first pediatric gastroenterologist at Miami Children's Hospital, and then there was another doctor, Dr. Serlin, came and joined him, and then Jesse joined them the year after. Jesse Reeves Garcia, which he did a podcast with him.
And what year was that Jesse joined? I didn't ask him about that history.
Yeah,
that was a few years ahead of you.
No, only just one.
Only 1 year ahead of you.
Yeah, he
Only
was.
1 year ahead of you.
He was in. I think he started '89.
Okay.
Yeah, it was in '89. He started with Dr. Ruiz Isasi. I'm a little older than I'm a little older than everybody.
Oh, you don't look older.
Yeah, but Jesse was actually 3 years younger than me, and he's still 3 years younger than me.
So you've been part of the staff of Miami Children's now for the past
35 years.
35 years.
35
Wow.
years as a an attending at
Yes.
Children's, and 3 years prior to that as a resident.
Yeah.
And then prior to that, I lived in the neighborhood. How about that? I lived in the neighborhood. I lived since 1965. I've been going to Miami Children's Hospital as a patient at one point.
Wow.
And I used to ride my go-kart in the parking lot of Miami Children's until the cops would come and throw me out. So I've been in that institution all my life, pretty much. It's been a blessing for me to be able to do this. I'm really, really been
and
very
see the
blessed.
growth of the
See
hospital, and
the
actually, and your practice too. It goes.
yeah, and see how the practice grew from. Now we're 7 gastroenterologists.
Yeah.
Uh,
No, it was you and Jesse who hired me in 20, 2009.
2009.
2009.
That's right. Yeah, we were
2009.
alone for we were alone. There were some other doctors that had joined us in the
Uh-huh.
past, and we were so there were four of us at one point. And then we split off, and me and Jesse were by ourselves for a good 5 years. That was overwhelming. Overwhelming. We
We're
needed your
busy.
help, and
We're
Dr.
busy.
Gomara came in
And
after, and
Roberto came
yeah,
at the same time with me.
yeah, and that was a blessing for us, because we needed to grow, and now we're still
Yeah.
doing that.
Yes, we keep
We're still
on
growing,
working hard.
and it's been a real
Working hard.
blessing.
So let's talk a little bit about the topics of today, abdominal pain.
Yeah.
Can you describe a little bit about so like how often do we see patients in our
Yeah.
practice of what's
Yeah. Well,
with abdominal pain?
yeah. Yeah. Chronic. There's a phrase called it's called CRAP, chronic recurrent abdominal pain.
Uh-huh.
Is the it's one of the most common diagnoses that we encounter in pediatric gastroenterology. It's because it's chronic recurrent abdominal pain in the growing years, and pediatrics is a growing science. I mean, it's during the growth potential of a child from infant to childhood to adolescence to young adult. That growth parameter dictates a lot of different pathophysiologic mechanisms that will be manifested by abdominal pain. And when you encounter a child at any age, infant, newborn, infant, childhood, adolescence, young adult, it brings on, in a sense, a very negative connotation of disease, meaning the parents are very scared and nervous that there is something potentially very dangerous to their child.
So you describe chronic, so meaning that so now we are talking about patients who'd be having the abdominal pain for a certain a period of time. Plus, and you like to focus also when you see your patients based on the age group.
Yes,
What would be the most common cause or the most common type of
exactly.
abdominal pain that they can have?
Right. There's a list. I always say there's a list of diseases in pediatrics, and that list varies with ages. We mentioned the simple things. Newborns, children under a year. Children in the growing years from, let's say, 2 to 5 years of age. Children after that, children going the prepubescent period, and then children in adolescence to grow into adulthood. Those milestones dictate different pathologic presentations of disease very commonly. And you can organize yourself because you see a kid that's 8 years old with chronic abdominal pain. It's unlikely, let's say, he has a let's say a very chronic inflammatory disease, for example, inflammatory bowel disease. We see it more in prepubescent and young adolescents more so. It doesn't mean it doesn't exist, but you see it more in say the older patients. Another example of significant pathology in a patient in the growing years and adolescence, the development of disaccharidase enzyme deficiencies is seen more in, let's say, young adolescents or adolescents
Which
more
that
so.
type of pain, it would be like a disaccharide, it's the digested enzymes, and it would be more kind of food-driven abdominal pain of any other
Exactly,
intolerance,
exactly. Food
of any
driven.
other intolerance. Now, when you are seeing a patient with abdominal pain, so now you have determined the age, the history. What would be concerning points on your evaluations about
Right.
more serious conditions
Yes.
on the discomfort the
Yeah.
patients are?
We'll call those the red flags. The red flags on presentation, and then so you incorporate the age of the patient, and you look for specific red flags that are seen in different age groups. But that being said, the classic red flags of persistent abdominal pain, vomiting, diarrhea, fever, different types of diarrhea, blood and mucus in the stool, vomiting of a certain time that brings on bile or significant severity. All that equates to a red flag, and it goes along with a potential pathologic diagnosis. Because we got to determine, and especially in pediatrics in the growing years, we have physiologic or functional phenomena that create abdominal pain. Functional mean the same function, the physiologic function of digestion can be presented to a patient that's 9, 10 years old that doesn't realize that when you digest something, you feel things, and it'll be manifested as pain
Yeah,
to
we're
the
gonna go
parents.
to that area of functionality. But first, I would hopefully like to address the issue of pathologic type
Yeah, sure.
of abdominal pain. And so you mentioned a red flag, so it's a bowel, which means probably it's about a bowel obstruction within
Yes.
the discomfort, persistent or high fever, lack of weight gain or weight loss,
Weight loss is key.
and so would you also look into the specific areas to related to the organ involved
Yeah.
in the abdomen where the pain is being described?
Right. So we talk about quadrants in the abdomen, you know, right upper and left upper, right lower and left lower quadrant, four quadrants of the abdomen, and that kind of like it in a sense describes or accentuates the anatomy. In the upper quadrants, we see more of the upper intestinal tract. Esophagus probably being more in the chest, esophagus, stomach, proximal small bowel. That's in the you're seen in the upper quadrants. You have other organs there besides the stomach. You have the extraintestinal organs like the pancreas and the biliary tree, the gallbladder, and the liver in the upper quadrants. So those can manifest if there's an inflammatory condition, which is the most severe, an chronic inflammatory condition in the upper abdomen will be manifested in those particular organs more so. In the lower organs, in the lower quadrants, excuse me, the lower quadrants, the right and the left, you start incorporating more of the intestinal manifestations or the intestinal etiology of pathology of disease, the small intestine and the large intestine. And then certainly in the lower quadrants, you have extraintestinal organs like the kidneys and the bladder and the excretory, urinary excretory, and then certainly the sexual organs involved, whether female or male. So that's more on the lower quadrant manifestation. So the quadrant of eliciting pain, and then the other thing is the pain localized or is it migratory? And a lot of times, if these pains are migratory, may manifest in the top quadrants and accentuate more in the lower quadrants with time. Those are migratory process because the whole abdomen, the whole abdominal cavity involves all quadrants, all four quadrants. So that's why it helps us to ask the simple question: where's your pain? And where is it? Does it rebound? Is it manifested in your physical exam or not? Does it come and go in a particular sequence, meaning at night, in the day, after meals, without meals? All these questions that you ask will delineate the physiology of, let's say, the intestinal tract and how that's manifested in an organic or functional diagnosis, meaning a disease process. So it's very important, like we always talk about, your history and your physical, especially in the abdomen, and we can see a lot. We'll go into all why we do all these workups, which
Yeah.
sometimes are, pretty intense.
Can you give us in your experience? I mean, based on the area the pain is localized, and kind of also grouping the patients based on age group too, like the type of abdominal pain that you encountered more common in your practice.
Yeah. Well, the types are, we can describe them by their functionality, meaning it could be, sharp, boring pain associated with other physical findings of a rigid abdomen, and let's say associated symptomatology like, fever or alterations in digestion, meaning constipation or diarrhea. When you have these inflammatory type of signs and symptoms, that equates to a more severe, more acute process where you got to intervene or things are going to go downhill very quickly. So that manifestation, and I always say it's fairly easy to diagnose in a child because their body will tell us what the problem is, even in the physical examination and the history that you get. So, and then some pains are, like we said, physiologic pains that go with the physiology of digestion. An example is a simple example, because when you're digesting, the bowel is not a static thing. It's a organized, coordinated movements of motility and secretions that are guided by smooth muscle contraction, neurologic pathways. All this can manifest into a patient saying, I have pain, if they can talk, or manifest pain by, in babies, colicky nature, or manifesting one of these abnormal signs that I mentioned, like vomiting or changes in bowel consistency in diarrhea. So the clues can be very physical, and you do that in your exam, but the clues can also be, a functional, because there is a functionality of movement in the bowel. It's not a static organ system. It's a very mobile, coordinated.
So you mean that during that digestive process of the food of the patient, that contractility or contractions of the gastrointestinal tract with absorptions, it can be reflected on any patients or any kids as an abdominal pain. They can sense that normal digestions as an abdominal pain, and that can be of some concerns for the family.
Exactly, because a child doesn't a child under that's not even a teen, even a teenager doesn't can't tell you I have heartburn, for
Yeah.
example. They don't manifest it well, or the description of it. They just know that when they wake up in the morning, they don't feel right. They may feel nauseated, or they'll throw up when they're on the ride home to school. That is brings a lot of anxiety to the parents. Why? Because parents, categorically, fear, and fear comes into play in pediatrics a lot. They fear for the worst. And if I ask this question to all my parents, what's your biggest fear? They say cancer.
Hmm.
And
Which is something that we don't see often in our
something, thank
practice as a
God, we don't
cause of
see.
abdominal pain in kids.
Exactly.
And now it's still open, just to stay in the focus of contractility. It is common that you see kids with chronic abdominal pain linked to constipations or these
Yes.
abnormal contractions and retentions of fecal mass in the intestine.
Any alteration in the motility of the gut, whether slowing or increasing or accelerating, will manifest in some type of painful dysfunction
Hmm.
that a child will describe. So because again, it's a motility organ system, so the transit time, whether increase or decrease, can alter. Example, decreased transit time in the bowel increases bacterial overgrowth. It increases retention in the stool, in the colon. That causes more bacteria to grow, solidify the stool. The stool gets hard, for example. It won't flow with contractions. And then the bowel needs to say, well, I need to contract more to get this guy out of here. And that in itself can be a sign of pathology. So alterations in the way the digestibility of the intestine can really affect the clinical presentation.
Yeah. I'm going to give you a few examples of causes of abdominal pain. Jump in at any time
Yeah.
if you feel like we're leaving something important behind. So let's say a young or school age, early school age kid that come to see you with epigastric abdominal pain, so pain in the middle quadrant, right above the belly button. Would you often see linked to that, like what you mentioned kind of before, gastritis or H. pylori infection?
Yes. Yes. I mean, gastritis is an outcome hyperacidic environment. And what our approach is, what created that hyperacidic environment that's generated in the stomach, that's where the acid is made, and causes a cascade of dysfunction in both motility and production of that acid. So that cascade of event that it can be presented very very nicely in the upper quadrants as we talked about, and above the umbilicus,
Hmm.
and that manifestation can lead into chronic inflammatory conditions due to this dysfunction of motility and hyperacidic component or production. So the hyperacidic component example, it can cause two things: cause dumping of the stomach or retention of gastric emptying. It could do both, and that in itself will set the whole rhythm of digestion and the whole rhythm of that whole problem, because you eat a meal and it takes many hours for that to be processed, correctly, destroyed it or broken down in the stomach, and then digested or broken down further in the small intestine, digested and absorbed, the nutrients absorbed in the small intestine. That process is time consuming, in the process of your normal activity. And then when you are awake and you're in school, because most kids are certainly in school, that outside environment of being in school can affect that proper digestion. It can
Mm.
alter it just like that. So we're talking about the external world of a child in the growing years, would be in school, most of them, can really, really affect the dysfunction of digestibility in a growing child. So that's why school becomes, I don't want to go to school. What came first, the chicken or the egg? Is there really a pathologic etiology causing this, or all these manifestations due to, we'll call it anxiety, which is very real.
Yeah.
Anxiety is the autonomic nervous system. I give the example. When I was a young man, I used to play American football, and I swear that, and I did it for years, even in college. Before the game, I'd throw up until I hit somebody, and then it went away.
Were you having pain too, or mostly the
No,
dry
it was
heaving
just
and throwing
nausea.
out with the nausea and
Yeah,
the
and I had to throw
just
up,
right before the game, and then you feel better?
and I felt better. And I use that example of what we see, day to day in our office. You know, kids are driven. I mean, kids, they don't have any downtime. They go from school, they go to after school activities. They got them running all the time. They don't eat right. All that stresses the digestion.
Yeah.
Because as we know, you got to eat quietly, relax, and let digestion take place. It happens in los viejos, like people
Mm.
like me, but but in kids, it's worse. But our culture doesn't allow them to be
Yeah.
kids.
And then obviously you're stressed up in school due
Yeah.
to any reasons that's going to aggravate even more the way they reflects that type of discomfort.
And that's why it's the most common really diagnoses that we see, chronic recurrent abdominal pain that leads to medical intervention to give a mechanism, to give an answer to these poor parents that are fearful that there's really something wrong with my child.
Which most of the times it's not going to be organic. It's going to be more outside
Exactly.
the triggering factors of the discomfort.
But that's very real, you
Yeah.
see? And we have to treat it as reality. Not say, like, sometimes if you don't, you know, in a sense, communicate this to the parents, and you say, I've seen this before, there's nothing wrong with them, and just blow them off. The parents don't want to hear that. They're really scared. And you need to address that.
Yeah. Let me ask you, because you mentioned also about food. I mean, so many things to discuss here today. In terms of food-driven abdominal discomfort, that becomes in terms of intolerance of any kinds, of food sensitivities, or food allergies leading
Yes.
to abdominal pain. Would you see that often in your practice too?
Yes, we see a lot. That's what we, let's say fairly recent in our development, and let's say the science of pediatric gastroenterology, because when I started, it was just beginning. But now, a perfect example, the whole allergic mechanism. not only food allergies but environmental allergies, how they play a role in this hypersecretion physiology that causes all of dysfunction.
How an allergy that is environmental, meaning that you're exposed to respiration, would
Yes,
affect your gastrointestinal tract?
we'll call it histamine, because the release of histamine, whether it's initiated by a foreign protein that the body reaches as foreign, or pollen in the respiratory tree releases histamine, and that causes a whole cascade of events, especially infiltration of eosinophils at the level of the mucosa and submucosa in the intestinal tract. It could be throughout the whole intestine, starting in the mouth, esophagus, stomach, small and
So
large
even food
intestine.
allergy, I mean, like environmental allergy, as you say, is linked to
Yes,
abdominal discomfort in some
very much
patients as
so.
well.
And we're just tapping into that recently. And I think it's very important that that we as a as an entity, a pediatric gastroenterologist, realize there's a lot of literature on it, and we see it, the manifestations of it. And I call that, we found the mechanism. And that's what I tell my parents. I go, we need to find what mechanism is causing this dysfunction, whether it's functional pain or pathologic pain, meaning there's an organicity involved that causes some dysfunction. We need to still feed what is that
Mm.
mechanism that's igniting it. That's very important, and that's what our workup does.
At what point during the evaluation of your patients you decide to start? It makes you concerned to the point that you want to start doing some labs,
Yeah,
and then the type of labs or laboratories that you would do in your
yeah,
patients. I mean, including imaging.
yeah. Well, one thing is, depending on what age bracket we're talking about,
Hmm.
and that'll bring up red flags sooner or later. Depends. That's very important. What age group? You tend to, in a sense, well, I always say what's common is common. An example. I'll give you an example of chronic abdominal or colicky pain in an infant under 6 months. We always talk about gastroesophageal reflux or benign infantile reflux or gastroesophageal reflux disease. Two entities have seen in this age group very common. And a common etiology of that would be intact protein allergies. We're talking about common things that will lead a patient to have significant colicky or abdominal pain or perceived abdominal pain by the parents in a baby under 6 months, after associated with maybe alteration in stool pattern or vomiting. That's a common presentation, and we're talking about what is common in children under a year. That would be a very common one. Differently in a child that in the growing years, in the growing years, during the growth spurt, prepubescent to early, puberty and early adolescence, and there's a alteration in growth potentials, and maybe some alterations in bowel habits, or even the velocity of weight going up or down, usually down. That would alert for more organicity
So
for
meaning like a red flags with the abdominal pains, that would be your concerns to start thinking about doing labs on your patients. That would
yes.
be either blood test or stool test or imaging
Yeah,
in
I
some.
think the the key also here is the chronicity uh, of that complaint,
And chronicity means time.
the time. I mean, when we see our patients, and I will use the example of, say, early adolescents, they've been going up and down with, recurrent, chronic, recurrent abdominal pain or abdominal dysfunction for even years. They come to see us. Now it's time to look at the mechanism workup, which is blood work, specific blood work, looking for mechanisms, stool test, looking for the digestibility of the foods, proteins, fats, carbohydrates, and sugars in the diet, doing imaging studies to see if there is an indication for abnormalities of the flow of the bowel, the way the way the bowel
Hmm.
moves. Example, we do a lot of imaging studies looking for, and endoscopic evaluation to really see. I say, like, we need to read the map. What does that mean? We need to look at the tissue, the histology, because by doing that, it gives us a history from the past of that presentation, and really fine tunes what mechanism has been affecting the symptomatology by reviewing the cell line that's involved in the tissue, meaning what cells, eosinophils, neutrophils, lymphocytes, different types of lymphocytes can be seen in the tissue and gives us a very clear evidence of this has been going on for a long time. This is a pathologic mechanism. This is a functional mechanism by just looking at the histology. That's why we do endoscopic evaluations many times. It gives us
We get a lot of concerns from family when we, as a gastroenterologist, we feel the patient needs either an upper endoscopy or a colonoscopy, and then sometimes freaked out. So they say it's an aggressive, the kid is going to have to be under anesthesia,
right.
and I'm concerned about the risks versus the benefits that the procedures they have. In your experience, is a super risky procedure to do an upper endoscopy
Not
or
at
a
all.
colonoscopy in your
Not at
patient?
all. Thank God it's not at all. Not at all. We've kind of fine tuned it. I always say when I first started, we used to have the endoscopes where you had to look into it. You didn't have a nice screen, and we were looking into like this. And gastroenterologists back then used to mumble. Why? Because they're looking in there and going, "Oh, I see a little something here. I'm not really sure what I'm seeing." But now you don't need to mumble. You look at a screen and you can see a beautiful image of what the lining looks like, and the reality is by visualization, that beautiful visualization, you really can see chronicity of disease very nicely. So when you weigh things out in the utilization of propofol, the anesthesia that we use for this procedure is very, very safe, very short acting. So you weigh all this out, and when it's time, especially when the chronicity has been going on, other things have been done, we need to get to the nitty gritty, and that's the best approach.
And we also have the capsule endoscopy too in
Yes,
some patients that we've been using to. So, I
which
mean,
is an
so sometimes not
ex
even to do anesthesia in patients that we are foreseeing that maybe something wrong in the deep into the small intestine that we
right.
or areas of the small intestine that we are not able to reach with that regular endoscopy or
I call that
colonoscopy.
no man's land, where no man has gone before.
That's a good that's a good
So
point.
this capsule, it's like a big horse pill. You swallow it. A kid over 6 years old usually can do it pretty good. They swallow it, and then we see a tumbling of a capsule going through the whole small
Hmm.
intestine, and it's a beautiful thing. It's a beautiful to be able to see the villi moving and the vessels, and when a compromised bowel deep into the
Hmm.
small bowel where no man has gone before, you can really see some occult pathology. So it's an excellent tool in some of the more difficult patients that we encounter.
So in terms of pain and that specific constipation, so pains, I mean, patients that coming with chronic constipation and abdominal pain, you've been doing for a while also a very unique or special procedure, which is anal rectal manometry.
Anal rectum manometry.
Can you let us know a little bit what is an anal rectal manometry and when you see that your
Yeah.
patient needs this type of testing?
Well, I mean, the anal rectal manometer it measures motility of the distal bowel. It's anal, rectal, the anus, the rectum, and we can go up into the left colon, into the descending colon, up to the descending colon. We sometimes use the same catheter, just insert it longer to evaluate for
So
what
this
something
test
called.
that doesn't require anesthesia,
No, doesn't require anesthesia.
and it's a safe
It's
procedure
a
too.
very safe procedure. I mean, I do it in little infants that have really out for something called Hirschsprung's disease or aganglionosis of the bowel. It's a migratory disease, congenital, born many times the first few months of little babies that are born with a lack of these ganglion cells, which is what causes a relaxation of the bowel, the ability to initiate a anal rectal reflex, meaning when the rectum is full of poop, it sends a message to the anus to relax, and then the rectum pushes. That reflex may be abnormally or not present if you have something like Hirschsprung's disease or congenital aganglionosis. So that's a beautiful test to look at that, and we do that all the time. Babies that have chronic constipation. I mean, I have babies, thank God, that are normal, and I really know that they're normal, but the anxiety of going to the bathroom, and especially in young parents, is very, very high. This test does not need anesthesia. It does not hurt the baby. The babies are going to cry anytime you put in a little something in their behind, or anybody. but it doesn't hurt. It's very lubricated. All it does, we insufflate a balloon, which is hooked up to a sensor that's hooked up to a computer, which looks at different colors. Depending on the color, it'll determine the pressures of contraction and relaxation. And you have to have a coordination of contraction and relaxation to defecate. Really, the act of defecation is a very complex neuromuscular phenomena. It's incredible what God did, but it's an amazing way of, why babies or children don't poop until they're a little older to understand what has to occur. So that we see that a lot in children in the growing years, under 5 years, chronic constipation. From what? From holding their stool. That's probably one of the most common diagnoses we see, the encopretic child. Encopresis is a functionality of lack of defecation due to behavior. It has nothing to do with neurological, neuromuscular problems. Thank God, it's all behavioral. But this is what I'm talking about: being in tune with the body, especially a child that's under 5 years of age, and not knowing that you have to sit. The reason why you sit why we all sit is you have to. There's a curve going from the rectum to the sigmoid. You got to go through a curve, and when you sit, you straighten that out. That straightening sends a message to your head: you got something down there, push it out. It's as simple as that. But it's a learned behavior that you don't think about that. You're born without the ability to poop, and well, that's why babies have diapers. They don't know what's going on yet. So I mean, we use that procedure, especially in little babies, to take out that fear that there may be something wrong. And what we also find a lot of times, um, what it's called pelvic floor anomalies or anal rectal malformations, not only neurologic but muscular, or they're all migratory congenital
And
problems.
this will be more often early on in life.
Yes, more often early, very early, that you find these things, because in order to poop, the anus has to relax,
Yeah.
and it can't. You might have a web. You might have a anus that is anteriorly placed or ectopic or narrowed, or you might have a diaphragmatic web that forms around the anal ring. And many times, I've had the pleasure to being a teacher
Hmm.
at Nicholas Children's. I always call it Miami Children's, but Nicholas Children, to teach the residents.
Well, you were one of my teachers
Yeah,
early on in life too.
yeah,
That was back in
that was
the
my pleasure.
90s, mid
Yeah,
90s.
yeah, that's right. That's right.
Yeah.
Yeah.
So those cases with either malformations or aganglionic segments of or colonic aganglionic segment, you will have to collaborate with the surgeons, with the team of surgeons, to help you up in the
Yes.
fixing or the cure of the problem.
Correct. See, working directly with the surgeons is part of this whole thing. There's a pelvic floor clinic that we have at Nicholas Children, run by the surgeons. Dr. Calisto
Juan
is, yeah,
Calixto.
Juan Calisto, excellent surgeon. He's been phenomenal in working with him, and dealing with these patients with pelvic floor anomalies, or so imperfect anus, Hirschsprung's disease, ectopic anus, things like that are sometimes missed, even by. I'm not criticizing any physician, but sometimes criticized by physicians that don't look at the butt. You got to look at the butt. And my mentor Dan Kaplan used to say, you better put your finger in their butt, because you're going to find a lot of problems by doing that. And that's what we got to do. Because if there's a problem with defecation, you have to see how the anus is reacting. Very simple.
So yeah, it's a good physical exam, top to
Yes.
bottom, on
And
the
we got to
patient.
teach
That's
that
pretty
to the
much it.
residents.
Yes.
They're all in their computers all the time.
Getting gathering a good history,
Yes.
interacting with the kids, with the families, and then a good physical exam, even before jumping and start doing any type of test.
Any type of test. You get so much from doing that.
Yeah.
You'll get the diagnosis even before, but just by doing that.
Let's in the last few minutes of this talk, I believe it was 1988, a group of experts they met in Rome. Then I think the first 1990, the first number one Rome criteria in terms of what you have mentioned already, functional abdominal pain or recurring chronic abdominal pain was developed. I think 2016 was the last meeting.
Yes.
I think it was now we are going through Rome 4 criteria. I think we are due for 2026 for the fifth
Wow.
criteria.
Wow.
So you mentioned this before. I think this is important too, and I think, I mean, you gave us like a very synchronic and nice explanations what these patients during digestions and absorptions and contractions or motility, they can reflect abdominal pain that is functional.
Yes.
So a group of patients that after they have gone through this significant amount of tests or history or physical exams, and you are not finding anything wrong, like it's no organic pain. So they
Yes.
continues with good amount of abdominal pain, and you are not seeing anything organic. So at what point you tell the family this is functional, and can you let us know from your
Yeah.
point of view a little bit more about functional abdominal pain?
Yeah. Yeah. So I call that my mechanisms workup, as I
Okay.
mentioned before. And you always want to rule out the pathologic mechanisms that involve, inflammatory diseases, allergic diseases, malabsorptive diseases, infectious diseases that can cause, significant pathology. So you want to try, if you'd be, especially it's been depending on the age group, depending on, the what classification of age group you're dealing with, you need to address all those pathologic mechanisms to rule them out or rule them in order to go to the functional phase. Let's just say we've gone through all those tests that we do. It involves blood, stool, sometimes some endoscopic intervention, some other imaging studies that we do, and then it leads us to find we've ruled out the list of diseases that exist, and now we go back to the function of the autonomic nervous system, the nervous system that controls, or they call it fight or flight reaction, the nervous system that controls secretions and motility, and that nervous system is affected by the external world.
And this is what some people call the gut brain. So
Yes,
the
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 gut brain.
gastrointestinal tract
Yes,
has a sound nervous system
it does.
that
And
it connects us with the central nervous systems as
yes,
well.
it does. And that's when we get into the functional etiologies that we rule out the list of that
Yeah. And
let's say
it's not
they're
like the
obvious.
patient is crazy or anything. It's like they
No.
really have sensations of
Exactly.
discomfort and pain.
I learned this the hard way because if you tell somebody, you tell the parents, oh, it's all psychosomatic, they're crazy. That doesn't help anybody. Doesn't help the patient, doesn't help the family, and you're not being a good doctor by telling that conclusion like that. So you need to address that, visceral functional discomfort is very real, and it is affected by the nervous system that is affected by the external world and the internal milieu. We always talk about the internal environment or the microbiome as a center of if there's dysfunction causing this dysmotility or these functional visceral phenomena just from having abnormal gut flora. It's a simple thing, and that is affected by the nervous system too.
And that gut flora, I guess it can be affected basically you've been exposed a lot to antibiotics or
Antibiotics
diet or the
or
type of diet
diet,
that
exactly. Especially in today's world, the diet, the inflammatory diet. Everyone talks about the seed oils and so forth. How that, and it does cause a significant inflammation of the bowel and cause malabsorption, maldigestion and so forth, and purely for that, and bacterial overgrowth and so forth can cause this phenomena of the microbiome. So that's the central part. It's almost like the brain of the gut talking to the brain of the
yeah,
brain
yeah.
of the patient.
Can you tell us? I'm seeing a group or a growing group of teenagers being
Teenagers.
exposed to cannabis,
Yes.
that they are coming with either this
Hyperemesis.
hyperemesis, cannabis-induced hyperemesis syndrome, or just inducing chronic abdominal. Is it something that you're seeing too
A
often?
lot. We see it a lot. You know,
So how
THC,
that happens? Yes.
yeah, THC, it causes hyperemesis because it causes hyperacid secretions at the level of parietal cell. Back in the old days when I was a young man, they call it the munchies, the desire to want to eat. But we've seen in adolescence, especially because, again, we're talking about the physiology of the growing years. THC has a significant stimulation to the parietal cell in the stomach of hypersecretion. That hypersecretion stimulates the nausea receptors in the cardia of the stomach and causes a persistent, nausea, causing, early emesis, and that could be repetitive, and it could be especially, and that happens more. We've seen it in the physiology of the growing years, not in, let's say, you're an adult, you don't have that growth hormone stimulation anymore for hypersecretion. Now in your growing years, you have growth hormone stimulation for hypersecretion, insulin fluxes, and then you have THC, which is a chemical that will do the same thing, especially in the physiology of a growing patient, different than someone that's already an adult. You don't have that effect. So we see a lot of that. I mean, we just diagnosed another one this week in the hospital, a 15-year-old
Hmm.
female. And then all the thing about
Yeah.
they don't
I would
want to talk.
definitely you would recommend to stop being
Oh,
exposed and
oh yes,
smoking
for sure.
marijuana.
Yeah, it doesn't. It's not helping anything. It doesn't even give you a nice buzz, so to speak.
Yeah, it's a complicating
It is.
daily life
Yeah.
on those
Yeah.
teenagers.
So but that let's say it's a good diagnosis because it's cause and effect.
Hmm.
So you're able to help the patient by finding that cause and decreasing the effect. This is what our goal is in chronic recurrent abdominal pain. What is that cause? What I always say, what is that mechanism? That's so liberating to identify it objectively, not like because I'm the doctor, I know what I'm doing, you don't know what's going on. I don't. It's not good to approach anyone like that. If you show them the evidence, and thank God we have the history of research and so forth, showing that these tests that we do are evidence based and come to realistic conclusions of the etiology of the dysfunction. That's key. So it's been very helpful, and utilizing these protocols to identify the cause of chronic recurrent abdominal pain.
Well, I think it's been very dissective, a masterful class
Yeah,
on it's a good summary. Maybe we should add like a part 2 or 3
sure.
at some points on
Yeah, we
this. It's
can
very
do that.
extensive
It's
topic.
very
It's very
extensive. We
extensive
just
topic.
dabbed into it.
But I think you summarized really well. I mean, important cause and the mechanism of
The mechanism is the key. It liberates everyone. No one likes to see, oh, don't worry about it. It's all in his head. You're not helping anybody. You're not helping the patient, the parents, and you're not really finding out what the cause is, which is very important, so you can address it correctly.
that's very good. Thank you.
You're
Thank you very
welcome.
much.
It was a pleasure. It was a
Likewise.
pleasure. Thank you. Thank you. Thank
That was good.
you. It was
That was
good.
good, right? You're like a movie star.
Yeah.